Greetings and welcome. I'm Dr. Karen Michelle. I'm the Research Program Lead for Occupational Health here at IOSH, and I'm also the Chair of the Scientific Committee for Accident Prevention at ICOH. And it's my pleasure to welcome you today to our webinar, Tackling Asbestos and Silica Hazards in the Workplace. This webinar is a joint event between the Accident Prevention Scientific Committee at ICOH, as well as the IOSH Construction Group. Before we start, I just want to do some housekeeping issues. First of all, I'd like to warmly welcome all the ICOH and IOSH members to this event, and thank you for taking the time to join us today. I think the interest is evident as we had over 1,900 registrations for the event. I want to also say at this stage, if you're not a member of ICOH or IOSH, please look at the links that will be put in the chat box, and I'd encourage you to join because the benefits that you will gain professionally really are immeasurable. Then also, if you would like to join SCAP, I will put in Jayandran's email address. He's the secretary, and you could pop an email off to him. There were 3 questions posed to you at entering the webinar. We're going to pose these same 3 questions to you at the end of the event, and we'd be very grateful if you answer them just to see if there has been any gain from hosting this event. In terms of muting the audience, you can imagine with an audience of this size, we have to mute the audience, but we are open to questions and answers, which we encourage you to put in the Q&A box. Please, I need to reiterate, questions that go in the chat box will not be responded to during the event. In the Q&A box, you also have the opportunity to upvote a question. So if you see a question posed by somebody else that you'd like us to answer, please just give it a vote because that pops it to the top of the list. And we know that we can then address the questions that most of the audience are interested in. Other than that, it's time to start our event. And just by way of introduction, I'd like to introduce the 2 gentlemen on the screen with me. Firstly, we have Dr. Kevin Hedges. He's joining us all the way from Canada. So a sincere thank you for getting up so early in the morning, Kevin. Kevin is a certified occupational hygienist, and he's a fellow member of the Australian Institute of Occupational Hygienists, and this despite the fact that he hasn't lived there for 14 years. So I think that's a tick and a nod to the work that Kevin is doing in the field. He's currently employed with occupational health clinics for Ontario workers in Canada, and in a voluntary capacity, he's a current board member of Workplace Health Without Borders, where he's also a past president. Welcome, Kevin. And then we have Dr. Sean Lundy. He's a chartered safety and health professional, and he's also a chartered building engineer. Currently, he's employed as the Director of Quality Assurance and Strategy at Tetra. He's also a Vice President at IOSH, as well as being the Vice Chair of the IOSH Construction Group. So welcome, Sean. We might also be joined a little later by Claudina Noguera from South Africa, who's the current president of Workplace Health Without Borders and also a past vice president of ICOH. So let me just set the scene very quickly before I hand over to Kevin. Asbestos and silica are both classified as Group 1 carcinogens by the International Agency for Research on Cancer, IOC. Exposure to these hazardous substances, whether occupational or environmental, can lead to severe and life-limiting illnesses such as asbestosis, mesothelioma, silicosis, and many other forms of cancer as well. The risks of exposure are manifold because we've got workers exposed with handling of the material, such as construction workers. We've got bystanders who are exposed, such as our OSH professionals who are conducting risk assessments and monitoring the work that might be taking place. Family members are being exposed when they are, for example, washing the contaminated clothing of workers. And even community members. Research is showing that in some places, community members up to 10 kilometers away from asbestos mines or factories working with asbestos are actually developing disease. The construction industry in particular faces significant exposure risks, making today's conversation both timely and critical. The webinar will explore key challenges, discuss mitigating strategies, and highlight best practice to enhance worker and community protection. We're going to start off with a very brief presentation by Kevin, who's going to set the global scene for us, and then we'll shift into a panel discussion. Kevin, over to you.
Thanks, Dr. Michelle. So I'm just going to share my screen and put it into slideshow mode, and hopefully everybody can see that. Is that appearing okay?
Looks good.
Okay, so yeah, just feel very honored to be asked to present on tackling asbestos and silica hazards, through the Institution of Occupational Safety and Health and the International Commission of Occupational Health. I'm professionally employed with the Occupational Health Clinics for Ontario Workers. I'm also past president and current board member of Workplace Health Without Borders. I just want to begin by acknowledging that I'm speaking from Ottawa, Canada, to all First Nations, Inuit and Métis people and their valuable past and present contributions to this land. As I am in Ottawa, I'm located on the unceded territory of the Anishinaabe Algonquin Nation. I'm professionally employed with the Occupational Health Clinics for Ontario Workers, otherwise known as OCO. There's a lot of really great resources on the website, and the OCO team is multidisciplinary. So I've just put a bit of a snapshot, a screenshot there of the different disciplines involved in OCO. Being past president, I just want to acknowledge the previous president, Jennifer Galvin. Fabulous work she's done, and also it's really fabulous to have Claudina Neguera just join as our current president. We recently offered webinars on a series on silica exposure from engineered artificial stone countertops, and also global webinar series on asbestos. And I particularly want to just pinpoint the silica control tool that's being made available from the British Columbia Construction Safety Alliance. There has been increased advocacy by Workplace Health Without Borders in recent years. If you go to the Workplace Health Without Borders YouTube channel, you can actually see all of our past webinars, but I'll talk a bit about that in a minute. Like I said, there's more of work done in advocacy. So as Workplace Health Without Borders have grown, and we now have an African branch, we also are getting more involved in advocacy. I just want to touch on engineered artificial stone, and I just want to recognize my colleague, epidemiologist from George Washington, also the past president WHWB, David Goldsmith. There's been an increased number of accelerated silicosis cases from working with engineered artificial stone. The toxicology is unique, so you can actually go and look at the previous webinars offered by WHWB. This is just a bit of a snapshot when we've been trying to get the message out about the concerning cases of accelerated silicosis. And in our second webinar, we got a lot of different people from different countries involved. And, this is a big problem worldwide. It's certainly very obvious in California and in Australia. And I just want to recognize Dr. Robert Harrison. And this is a fabulous podcast to get a good idea of what the situation is. And I also want to acknowledge Dr. Ryan Hoy from Australia, who shares a lot of information with us as well. And talking about Dr. Ryan Hoy, this is a paper he just recently shared with us, just to show the increased compensation cases for silicosis in Victoria, and you can see those the graph, and to the right there, that's in Victoria. They're from working with engineered artificial stone. So hence, there's been a lot of work in Australia to advocacy to ban engineered artificial stone. I was at a conference in Perth recently, and Dr. Dino Pizzianello presented. He really just talked about the all of the research being instrumental in banning the engineered stone, being a great catalyst. And the paper there on the right lower corner of the screen there, they're occupational hygienists with the IOH. So the Australian Institute of Occupational Hygienists really did a lot of advocacy to ban artificial stone in Australia as well. But there is, if I can just also acknowledge Dr. Graham Edwards, who, really was one of the founding people in Australia to promote the seriousness of this. There's all these workers out there who've been exposed who think they've dodged the bullet only to develop the disease in the future. So there is a strategic plan to look at this into the future. If I can just acknowledge Dr. Mani Banjeri, who talks about the California situation. By 2023, there was 52 cases. And then by November 2024, the total had reached 219, 26 lung transplants. As of early December, Cal OSHA had inspected 85 stone cutting shops and 22 orders were issued. So, there was an emergency temporary standard, and that covered materials containing more than 10% crystalline silica. And the permanent standard on December the 19th, 2024 is now in place. The permanent standard is expected to become effective in early February 2025, so very soon. And there's a Senate bill prohibits dry cutting methods and mandates the use of effective methods for fabricating stone slabs. And there needs to be comprehensive training curriculum on the safe fabrication processes and certification process by January the 1st, 2027. So, it's not just in California. This is just a study in Chicago, just showing the level of exposure, very high levels of exposure and from this pilot study. The problem with this material, apart from its unique toxicology, with the glue that binds the crystalline silica together, we're talking about nanoparticles too. So the smaller the particle, the worse it is for your lung health. Now, just to go to global asbestos, I just want to acknowledge both Alec Farquhar and Tuan Nguyen. Alec leads the Workplace Health Without Borders Asbestos Working Group. Tuan Nguyen from Vietnam is the past president of US WHWB. And we did have a webinar back in 2024 looking at a roadmap to an asbestos ban, involving the past president of ICOH, Yuka Takala, and Bob Ray, who's the Canadian UN ambassador. We've also presented at ICOH in Morocco, and Claudine, who's on this call as well. We put this presentation together. Now, I just want to quickly share information on the silica control tool. If we think about the risk of exposure, rather than take measurements, there is now a way that we can actually figure out how to control exposure without taking measurements. So the idea came from Dr. Hugh Davies, and then Dr. Melanie Gorman-Ning worked on it, and now it's come from BC Construction Safety Alliance over to the Occupational Health Clinics for Ontario Workers. It's actually in the legislation in British Columbia. They do mention the silica control tool, which is fabulous. And this is just a screenshot showing that if you work on engineered artificial stone, even with water, you can still exceed the limit. So basically, you just have some inputs into the tool, and then it tells you what the exposure is with and without the controls. Melanie actually shared this with me. So if anybody's interested in, collecting data and sharing the data with, Melanie. There's the email address. So you might want to send an email to Melanie to be part of the process. Many people are taking samples around the world at the moment, and it just makes the tool sharper. Just asbestos, they're the series of asbestos webinars that we've presented. And in one of the webinars, I talked about the Australian position. So I've just provided some guidance material, both from Safe Work Australia, from the Australian Government Asbestos Safety and Eradication Agency, and also the Asbestos Dust Diseases Research Institute. And just acknowledge Shane McCardle, who's the Manager International Projects. And I believe they're actually revisiting the e-toolkit for the elimination of asbestos-related diseases in developing countries. So that's my introduction. I just thought I'd give you a bit of an overview. Hopefully I didn't go too long. Back to you, Karen.
Thank you very much, Kevin. Much appreciated. So let us then jump into our questions and answers. I'm going to start. Sean, I think I'm going to direct our first question at you, if you don't mind. And I want to start by just exploring. We see the global scope of the problem associated with asbestos and silicosis, but in essence, in what environments would we expect to find them, and what kind of occupations are we, would we be likely to expose asbestos and silica to?
Yeah, so thanks, Karen, and good afternoon, everyone, for those in the UK, and hello, everyone else, if you're on a different time zone. So when we talk about asbestos, we're looking at in the UK anyway, probably older buildings built before 2000, because of course asbestos is not used in buildings built after that date, but we still find it in a lot of buildings. So certainly in older cities like London, there's a lot of properties with asbestos containing material in them. We find it in insulation material, fireproofing products, roofing, cement products, and generally the exposure will occur, of course, because we're disturbing it. So it's the creation of the dust, the inhalation of that dust into the lungs. So any activity associated with demolition or refurbishment work, of which there is an awful lot going on in a lot of towns and cities around the country. Routine maintenance work, so it could be your person turning up to maintain something, decorate, do minor changes to the building, and they can inadvertently become exposed. Of course, during the removal process, where we identify asbestos is not in a good condition, we may seek to remove it. So that removal process is particularly hazardous as well. And of course, part of our process to try and prevent that is to know where the asbestos is in the first place. We'll probably talk a bit more about that later. When we sort of move our attention to silica, or respirable crystalline silica dust, we typically find that in building materials. So sandstone in particular, concrete, brick tiles, increasingly engineered stone, which I know Kevin's already mentioned, and some countries, Australia in particular, but also I believe California is bringing in a ban, has already done that. Engineered stone contains a lot of silica, but also in industrial processes like glass and ceramic manufacture as well. So anything that involves cutting or grinding or drilling, even quarrying as well, and sandblasting, they can expose people involved in those activities to that type of dust. Both asbestos and silica are hazardous. Asbestos accounts for around 5,000 deaths a year in the UK. Silica less so, but that may be due to underreporting, because we don't tend to report silica and silicosis diseases in the same way. So both of these are the top two dust exposure hazards, really, that people are exposed to, both in maintenance work and construction, and in some manufacturing processes as well.
Kevin, can I ask you, building on that, I mean, one may then be led to ask, well, how do I know if there is asbestos and silica in the environment? And if it is there, how do we measure it?
Okay, so hazard identification is such an important step in a risk assessment. And, a lot of the older buildings, you've really got to go and engage with a competent person to go through the building and do a survey. And, you know, it probably may involve taking samples of different building materials. And then also doing a risk assessment of that material. You know, is it friable? Is it occupied? Is it easily disturbed? So there's different factors that you need to think about when you do the risk assessment. And then you can actually, you know, rank the risk and then figure out how you're going to deal with that material. There may be situations where you really need to remove it pretty quickly, because if it's in an occupied area, or even, you know, move people from that area so they're not exposed. There is just a bit of advice to everybody on this call. The Occupational Hygiene Training Association does have an intermediate module on asbestos and fibers. So, you know, this is really just covering, it's like a snapshot for your audience. But, you know, and I'll put a link in the OHTA web, like for the OHTA in the chat. But it would be great, you know, for the practitioners here to actually go and maybe do the intermediate course in asbestos. Now, silica's everywhere. It's ubiquitous. If you think about quartz, you know, it's one of the most abundant minerals on the planet. And, you know, if you cut rock, use jackhammers, drill, as Dr. Lundy said. So it's really important that people are made aware. And there is, OHTA does have an awareness course on silica. So it's really important that the hazard identification is in place first. Now you can measure both of them. You can measure silica in the air. You measure respirable crystalline silica using a particular sampling head called a cyclone sampler. So it basically takes a sample of what goes into your lung, and then you analyze the actual loading on a filter in the head, typically by XRD or infrared analysis. And then you get a level of a concentration or a mass on the filter, and then you divide that mass by the volume of air that you've actually sampled during the time. Asbestos, you actually sample for asbestos fibers, and usually use optical. You can either use optical microscopy to, typically you look at the morphology of the fiber, and you do a fiber count. There seems to be a move more towards using electron microscopy now as well, because optical microscopy doesn't have the kind of resolution to measure those really like smaller fibers that can't be seen using optical microscopy.
Yeah, I'd just add, Kevin, as well, and Karen, that I think the survey is really important. You know, there was there is an all-party parliamentary group on dust exposure, actually, and they've talked recently and produced a report around asbestos. And one of the strong recommendations, certainly in the UK, that's coming out is to use very high, you know, well qualified and competent asbestos surveying companies. And in the UK, we use UCAS to accredit those. So UCAS is United Kingdom Accreditation Survey. It's, you know, the body the government appoints, if you like, to accredit companies and to get the right survey done. So information's everything, actually. So in those, for anyone managing property, and if that property is older than 2000 in the UK, you must get a survey done, of course, and you must be managing asbestos risk in those buildings. But getting the right survey done is important. So UCAS accredited surveying company is what the HSE recommends, but they don't mandate it. The all-party parliamentary group is calling for that to be mandated, and I think that will be a really positive move, actually, in the industry. And I say this a little bit selfishly because, of course, Tetra are a UCAS accredited surveying company, and often we do end up redoing surveys at cost, a great cost, of course, because the initial survey hasn't been done correctly. There's been an accidental exposure. We've recognized there are gaps in the survey, or even if it's the incorrect survey. So they may be doing construction or what we call refurbishment demolition work off the back of what we call a management survey, which is really only a sort of survey to look at the management of asbestos in that area. If you want to do any work on the building or any construction work, you should be getting an R&D survey done, and that should be done by a UCAS accredited company. So there is a kind of shift in that direction, I think. And I know somebody has already asked a question about whether our standards are going to be lower. And I think it's going to go up, actually, certainly in the UK, because the government have recognised that the deaths from asbestos-related disease aren't falling. There's still 5,000 people a year die from asbestosis and mesothelioma and other diseases caused through exposure. We would expect that number to come down. But also, research they did last year seemed to show that young people are largely ignorant of asbestos risks. And that's true for a silica exposure as well in the construction industry. We know that workers in construction generally don't recognize the risks of exposure, and therefore, they're less likely to use control measures provided for them. So there's a whole education piece, I think, around this as well to raise people awareness, but also getting the right information. And then, as Kevin says, using the amazingly well qualified occupational hygienists available to you should you need to measure exposure directly, and getting that done in the right way is really critical.
Just to add to that, I'm sorry, Karen, just to add to that, the past president of ICOH, Yuka Takala, along with a lot of his colleagues, pulled together a paper talking about asbestos globally. And he basically said that the exposure limit is way too high. And he feels that it needs to be greatly reduced. So if you look at what's happening in Europe at the moment, they're really going for a much lower limit, because the limit of 0.1 fibers per mil used by many jurisdictions isn't anywhere near protective enough.
Yeah, no, I'd agree with that completely. I mean, I always sort of make the point that there is no safe exposure. Any dust you breathe in is harmful, but silica dust and asbestos dust is particularly harmful, of course, and leads to known disease outcomes. But yeah, educating people that they should be reducing any dust exposure really is an important thing. And I think lowering the standards is, or if you like, raising the standards but lowering the limit is actually quite an important thing to do.
Absolutely. I just want to pick up on a line of thought here, and at the same time address some of the questions that are coming up in the chat box, because one of the problems from a health perspective, and of course I come from a health perspective, is that with exposure to asbestos and silica, you don't know that you are developing pathology until it's too late. And historically, they've had very long latency periods. So those latency periods have been a problem in terms of diagnosing asbestosis, silicosis. You throw into the mix the fact that often workers who start to develop symptoms, they're insidious in the sense that they suddenly realize, well, I'm a little bit short of breath, I've got these very vague symptoms. They might go through a public health system rather than an occupational health system. It is known that there is a very poor understanding of occupational health and exposures in the public health sector. So those links aren't being made. Somebody asked about how long after exposure, do you have to keep files open? Well, my father was a typical example of 30 years after exposure, he developed asbestosis. It wasn't even diagnosed through his occupational health service. It was actually diagnosed once he was medically boarded. So those weaknesses in our occupational health system still exist, and it's a challenge for us to obviously address them. What I do want to highlight in terms of health is the difference, though, with the artificial engineered stone. In these cases, we are seeing silicosis much, much earlier. We are seeing silicosis in workers after 5 years exposure where they're already needing lung transplants. And we're seeing deaths in very much younger workers, often within 10 years of their initial exposure. So for me, asbestos and silicosis are two very, very significant and relevant conditions. We need to increase the knowledge base, not only within the IOSH fraternity, but I think there is a desperate need to also get the message out to public health, so they have this index of suspicion when they see people and they start to ask the right questions. So, you know, I think from the health side, we have some really important issues to address. But obviously our objective is to not get to that point. So I'm then going to ask you gentlemen, I know that we use the hierarchy of control. Using that, how do we then address controlling asbestos and silica exposures in the workplace? What are the things that can be done practically within the workplace? Sean, do you maybe want to jump in?
Yes, yeah, I'll jump in. Yeah, so I mean, I'll just make a point about engineered stone, actually, for those that don't know. I mean, the silica content in engineered stone is much, much higher than you'd find in any other product like, you know, marble or granite. There's a much higher exposure to silica, basically, through engineered stone, which is why there's been this call. I mean, in the UK, that all-party parliamentary group I talked about, which is, you know, looking at this sort of area, it was a group of clinicians actually who raised the concern because they were seeing cases and also they were worried that a lot of this exposure wasn't being either recognized and actually the disease wasn't being recognized either, or even reported or captured. So from a silica point of view, that's a significant issue. I mean, in construction, we often talk about reducing dust, you know, by using sort of mist systems or dampening down. It does have an impact. I'm sure Kevin will come in because I think there has been some research to show that perhaps it's not as effective as we'd hope it would be. You know, obviously, you mentioned the hierarchy of control, Karen. I mean, prevention first, then control. So, you know, that's how we work. And certainly when it comes to, regardless whether it's silica or asbestos, what we're trying to do is prevent exposure first. So, you know, preventing disturbing asbestos material, if you could, you know, by identifying it, managing it well. If it's in a bad condition, we remove it, do that safely. But actually, if it's managed in situ, then we have to make sure it doesn't get disturbed. And information is everything, you know, so if you're a contractor going into a building and you don't know there's asbestos, or perhaps, as the government seemed to indicate, if you're a very young person and you just don't understand the hazards associated with asbestos because, you know, you were born after the year 2000, which many people are, you know, and you sort of come across building works, but you don't know you're exposing yourself to those hazards because nobody's told you that there's asbestos there and you don't understand what it's about. So I think information is key. Prevention first, of course, don't disturb it. And then we do have regimes in the UK around different types of work. So we have, you know, unlicensed work, you know, licensed notifiable work and non-notifiable work are quite sort of slightly confusing array of different requirements, if you like, depending on the relevant exposure. So where people are working with known asbestos containing material, they must read asbestos essentials. They must take account of whether this needs to be done by a licensed contractor or whether it can be done by an unlicensed contractor, and there are many categories of that. And then there's a lot of guidance there to ensure that people doing the work do it in a safe way, so they reduce their own exposure, but also exposure for others by disposing of it in the right way. So this is, you know, waste that needs to be disposed of in the correct way for a licensed contractor. I think construction is a difficult one, and maintenance work, because you know, work has to get done. So people do, you know, cut stone, they do disturb buildings, and even in demolition, of course, there's a lot of dust created during those processes. Ideally, of course, what you want to do is to reduce that as much as possible. So reducing cutting, I think, is quite an interesting one. So getting things made to the right size and dimensions that you need it, so it doesn't have to be cut so much on site. Where it is being done in that way, using as you know, methods to suppress the dust as much as possible. And then I think, thinking about the hierarchy, you have to think about giving people the right personal protective equipment, and it has to be the right PPE. So making sure it fits. So fit testing, face fit testing is very important. And then I suppose, the other thing you need to consider is medical surveillance, health surveillance for individuals, particularly where they've been exposed to excessive levels. So if they've exceeded a workplace exposure limit, then you certainly need to get that recorded on their records. If it's asbestos, you want to be keeping that for 40 years. At the moment, a lot of GPs aren't recording silica exposure unless there's an identified issue, which, as you quite rightly said, Karen, can be quite a long latency period. So by the time people are showing symptoms, they're obviously quite ill, and the exposure may have happened a decade or longer ago. So that's a key concern, really, which is why I think we need to think a little bit more about reporting exposure. We need to, as practitioners, certainly as health and safety professionals, we need to be recognizing where workers are being exposed, where they may not recognize the risks themselves. So, they get an exposure, they cut a brick up, inhale a lot of dust, they go home at the end of the day, come back to work, and they're fine. But they do that repeatedly, and then over the years, they're getting, less and less well, and eventually they suffer, chronic illness, which is untreatable at that point, and will shorten their life tragically. And those are the things I think we need to be focused on.
So I just want to take us back very quickly, because Kevin, I've been asked a question and I thought, I don't think we really have answered this. There are members in the audience are saying, what do we actually mean by artificial engineered stone?
Okay, so it's basically crushed quartz, basically, and it's reconstituted. It's put together with a glue. And I think it's phthalic anhydride off the top of my head, but it's just, there's a number of different things they add to the stone to pull it together. It's microcrystalline, so when you cut it, it's, you form much smaller particles, and it's kind of got a unique toxicology. And I just want to throw in that, there's a lot of move now to replace artificial stone with other materials, lower quartz, but there's still inherent hazards in the substitute. So just by substituting it, doesn't reduce it doesn't reduce the hazardous materials or the health effects from the stone. I just want to kind of pick up on what you were saying before, Karen, if that's okay, about the hierarchy of control. I think what we're seeing with engineered stone, like I'm just referring to the podcast from Dr. Robert Harrison now, and it's not actually being banned in California. They're introducing a licensing scheme, and it's not going to be in place for some time now by the look of it. So these workers are still going to be exposed, whereas in Australia they have banned it. The other thing I just want to say is that just putting a respirator on and isn't going to be good enough. Even water, as I showed with that silica control tool, you're still going to exceed the limit. So it's layered. It needs to be layered. And Robert Harrison was even talking about using powered air purifying respirators, so much higher level of protection. So yeah, you've really got to kind of eliminate substitute, but be careful with the substitute. And then where you can, follow a layered approach. And I believe IOSH have been doing some amazing work, trying to understand the levels of exposure with different controls. I just want to also go back on that health surveillance piece. Dr. Ryan Hoy has really been promoting low-dose CT scans. So using, B readers to look at chest X-rays, there's some subjectivity there. Apparently, the sensitivity to detect silicosis using low-dose CT scans is much better. So, that's a really important message to get out there about the additional medical surveillance using low-dose CT scans.
Yep. And I think that's a very important one, Kevin, because, even in developed economies, not all workers have access to occupational health services. I mean, you know, we presume that lack of access is in your low and your middle income countries, but we know that even in high income countries, it's a problem. And the reality is, I think a lot of this artificial engineered stone is being used in those economies. You know, so the exposures are there. The workers who are doing these jobs are normally working for SMEs. They don't have the resources to put, you know, good control programs in place. They don't provide them with good quality PPE. There are so many dimensions to the problem. But Claudina, if you can hear us and you can possibly come in here, I'd like to ask you, a lot of what we've been discussing is giving us a picture of what is going on, you know, in high income countries. Do you see any action in the lower income countries in addressing, you know, the concerns with asbestos and silica exposures?
Hi, Karen. Greetings to you and everybody. Can you hear me?
Thank you. Yes, Claudina, it's great to have
Okay,
you.
good.
Hi,
Thank you so
Claudina.
much for inviting me to this webinar. It's most interesting. We do see action, and I can speak from South Africa itself. You know, South Africa was the third largest producer of asbestos for many years as a miner. Mining was banned a long time ago, and the manufacture and use of asbestos was also banned almost 20 years ago now. And then we have new regulation dictating asbestos abatement, which has come into being just recently, I think 2020. So it is obligatory for workplaces that have got, or for buildings that have got any asbestos in them, to be risk assessed according to the latest regulations. So that's a South African experience. There are, of course, many other low-income and middle-income countries that still use asbestos. And we know that globalization has shifted a lot of the asbestos work from high-income to low-income countries. And this is why we have the problems in the low-income countries, because not only have the manufacture and the products shifted across to be worked upon and still being part of the industry and being used in any number of sectors like construction. What's happened with that globalization is that the health impacts have also shifted from high income to low income countries. And we see a surge of asbestos and silica exposure related lung disorders in developing countries, particularly in occupational settings.
Thank you very much. And Claudina, just interestingly enough, I was reading just this past week an article on 2 confirmed cases of asbestosis in Congo, which is kind of, you know, it was a new phenomenon for them. Not that the condition is new, but the fact that the diagnosis is actually being made. And again, interestingly, you know, the case study showed very clearly, you know, the workers would go to a public health facility because there was no access to occupational health. And as a consequence of that, there was no link being made, even going so far as no occupational history is taken to try and even identify possible exposures in these workers. Yep.
I agree. I think that the link is not made, not because it's not known, but it's because of the fact that there's no surveillance and there's no measurements being taken. For a long time, it's been known that it's a link between exposure and disease development.
Yep.
Yeah,
Yep.
I was speaking to my colleague Mark Rhodes about this. He's worked in asbestos injury for many years, and we were discussing why the number of deaths in the UK don't seem to be falling when the government really expected them to start falling in about 2010. And he felt that actually diagnosis is a lot better. So, and obviously surveillance is improved. So we are seeing more cases. So unfortunately, tragically, people will have died from asbestos-related disease and silicosis, in fact, and not been diagnosed. And that's certainly improved. I was reading there was a study looking at silicosis saying that it was actually probably the most common chronic lung disease around the world, although our experience in the UK is slightly different because we seem to have a lot of asbestos still in buildings. So we're seeing a high level of asbestos-related disease, a slightly lower level of silicon-related disease, silicosis sort of cases. But again, that might simply be down to diagnosis, that people aren't being picked up from their exposure. So yeah, as Claudina said.
Before I start consciously going into the audience questions, I want to raise something that was brought to my attention, and I'm going to thank Kevin here for bringing this to my attention. One of the things that we talk about is bans, and we know that Australia was the first country to ban, artificial engineered stone. And one of the things that is going on in the UK is that before our last general election, there was a petition started to raise the debates in Parliament. And obviously with the general election being announced, that petition was closed. It is, however, open, which I was not aware of until we did some research for this webinar. And I just want to bring this to the attention of anybody who's resident in the UK, that the petition is open. The link will be put into the chat box. And basically, we need 100,000 signatures to raise the debate in Parliament about banning artificial engineered stone here in the UK. So any of those webinar delegates who are from the UK, please, I encourage you to go to the link and vote, and obviously spread the message out, because it's important for the health of our workers that we actually address these problems effectively. Kevin, you want to jump in?
I'll come in on that, Karen, but I can see that Kevin's got his hand up.
Yeah.
Yeah, I just want to jump in quickly. I'm just saying that through one of our occupational health clinics for Ontario workers webinars, we had an Australian chime in. His name's Peter Knott, and he's one of the authors on the paper that I mentioned. And, providing more rationale at why Australia banned artificial stone, engineered stone. They just don't have enough inspectors to go around all those shops. So, you might have a stronger compliance, but you just need the number of inspectors you need to get to all these fabrication shops. You just don't have that capacity. So that was another reason why, apart from all the research was done. Thanks.
Yeah, just on the petition. So it was Jim Shannon, who's the MP that chairs the all-party parliamentary group in the UK on respiratory health. And it was that group that considered whether a ban was appropriate. Now, this was last year, I believe, or 2023. They decided that it wasn't appropriate to ban, but that argument hasn't gone away. So, absolutely sign the petition and get government to relook at that, I think is definitely the way forward. And that APPG, it's a parliamentary group, so they consider things and they receive information from industry and research. So there'll probably be a bit of pressure in the construction industry to still use this material, artificial stone, because it has benefits to that industry. So there'll be competing arguments coming in the other direction. But I think there's a very compelling case that Australia has led the way on. And even California, I understand, has done the same thing. So it's certainly something that needs to be flagged. Yeah, absolutely.
Thank you. Sorry, okay, Kevin, I'm going to jump in and start addressing some of the audience questions, because we've got 36 questions and we've only got 15 minutes left. And I want to take some time at the end to kind of look at the role of the IOSH professional in more detail if we can. So the first question that I was going to ask, sorry, I have to go back to the top now because somebody's just added a question. The question is, do you think that, no, sorry, not that one. If a person disturbed the asbestos, but the air testing results came below 0.01 fibers per cubic centimeters, and that's their clearance limit, would it still be considered as exposure to asbestos?
Do you want to comment on that one, Kevin, first?
Yeah, I was reading the paper that Professor Yuka Takala was on, and I was trying to kind of convert what they were recommending, and he was talking about 1,000 fibers per meter cubed. That's what the limit should be. So I was thinking, how do you convert that into fibers per cc? So you divide it by 1,000 and then 1,000 again. So we're talking about 0.001. And if you think about using optical microscopy, we're not actually picking up all the fibers. We're not picking up all those small fibers as well.
Yeah.
So it's an empirical method. And really it's about, if it's there, and I'm just going back to Sean's, I had a good conversation with Sean the other day. if it's present and it's friable, just assume that people are being exposed and don't put too much reliance on the air monitoring. It's about controlling its source and looking at the friability.
Yeah, I mean, in the UK requirement is we have control limits and then short-term exposure limits, and then we have clearance limits. So the clearance limit is typically what we do if we've had asbestos work done and you stimulate maybe a procedure which will disturb the environment to see whether it will reach that clearance limit. But that's a very low number at 0.01 asbestos fibers per cubic centimetre. But very few people are doing work where they're constantly being monitored with personal monitors for against a control limit or a short-term exposure limit. I would just I would sort of suggest that, as Kevin has said, any exposure really is significant. So regardless of whether you can recreate the conditions and see whether it exposed the limit has been reached. So sometimes limits, these workplace exposure limits aren't always helpful, and sometimes they're used in the wrong way. Because actually we apply a LARP here, it should be as low as reasonably practicable in any case below any workplace exposure limit. So that's your legal duty, if you like. Certainly in the UK, that's how it's positioned, and I think it is pretty similar around the world. And that's a sensible approach. So you don't work up to a limit, you reduce it to as low a level as reasonably practicable, but anyone who seems to be exceeding a limit, then that's a cause for concern, may need further investigation. And certainly you'd probably want those exposures documented for future reference. So in 20 years' time, if they are going to, being diagnosed with silicosis or asbestosis or mesothelioma or any of the other diseases, it's recognized that they did have an exposure and that was likely to be a high exposure.
If I could just add to that too, if you look at the methods, and I think everybody on this call, you might want to look at getting more training, basic training in asbestos to understand the limitations, understand the limit of quantitation with the test, and also the limits, the problems with optical microscopy as well. And the fact that it's an empirical method. I think it's important people understand what we're actually measuring and how we're measuring it.
Yeah.
One of the comments that I'd make here as well is the fact that there is such disparity globally about what are safe exposure limits. One of the research papers recently that I was reading was saying that 0 is the safe limit. That's it. There should be no asbestos or silica, and research published just this year says that if you're doing indoor work with asbestos, you should be using respiratory protective equipment that gives you a protection factor of 1,000. Which again just basically means no exposure. I know there's a question from the audience about what kind of mask you should be using. Well, masks, in my opinion, are not the right PPE. They should be air filters, they should be respirator type units. There should be 0 exposure. I'm going to ask a question that it's been upvoted, so there's quite a bit of interest from the audience. And before I do, I just have to apologize. My dog was barking and I was trying to tell her to keep quiet. So I do apologize, Sean. I thought I was on mute.
No, that happens, doesn't it? It does happen.
Sorry. The question is, in say an emergency repair work to asbestos cement slate roof, and it's considered a minor repair job by most contractors, what type of mask should the operator wear in conjunction with other measures such as damping, etc.?
Is that one for you, Kevin, or one for me?
Why don't you give it a go, Sean?
Yeah, so there are masks available for asbestos. There is, as I think I mentioned before, Asbestos Essentials. My recommendation would be go to Asbestos Essentials, which is the HSE sort of toolkit and guidance pack for any type of asbestos work, and it makes it very clear in there the sort of thing you should be looking at. I think it probably recommends what we call an FFP3 mask, a disposable mask. It depends on the extent of the work as well. So we're talking about maybe not work that can be done by an unlicensed contractor. perhaps, but again, that would need to be checked. It's worth saying as well, any work on asbestos material, whether it's done by a licensed contractor or an unlicensed contractor, whether it's notifiable or not, it must be risk assessed. And the key thing that you should be thinking about is whether it needs to be done in the first place. Secondly, how do I reduce any breakage of that material to the lowest level possible? And then are there other measures I can apply during that process, which Asbestos Essentials will make some key recommendations around, in addition to the mask. So I think Kevin made this point earlier that the mask is not, it's the sort of last resort. You probably also need to consider the clothing you're wearing as well. So Asbestos Essentials talk a lot about wearing the right sort of coveralls and things like that, and then disposing of those in the right way. You don't want to be taking fibers by accident home with you on your clothing. So there's certain guidance around that. I think what I would suggest is real caution in any form of asbestos work, and checking that guidance out, the Asbestos Essentials, certainly in the UK, but it is freely available, so anyone around the world can use it. And there'll be other similar toolkits which are available for that type of work as well.
And if I can just add to that, Sean, there's the Canadian standard Z94.4, CSA 94.4, and the Australian standard, I think it's AS 1715 or 1714, either one of those. But it's the key there is you need a respiratory protection program. Just putting a respirator on somebody isn't good enough. It needs to be there needs to be fit testing, there needs to be training. If you're required a respirator, then you need to be part of a program. And it's really, you just can't, that's kind of a pretty broad question. You really need to go through the standard to understand the level of exposure, and also introduce this kind of, have a program in place according to those standards.
Yep.
Yeah, I'll put a copy of a link to that Asbestos Essential in the chat as well, just so if you've not come across it, and I think it's worth asking anyone doing work like that whether they're following it, and if they're not, I'd be very suspicious of whether they're competent to do the work at all.
Yeah. There's one question that I'd like to address here, because I think for me it really just it demonstrates the misunderstanding of the role of medical surveillance. So the question has been raised is, can medical surveillance reduce the risk of asbestos and silica? The bottom line is no. Medical surveillance is basically a measurement of how well your controls have been working. And in any occupational disease, if you start to identify disease, it's actually a clear indication your controls are not working, something is deficient, and they need to be addressed. The problem is with medical surveillance, and especially things like asbestos and silicosis, is that you can do all the testing now, but it's only down the line that you're going to see the disease. And in my opinion, that's where compensation becomes so vitally important. And for many workers, compensation is not an option. There aren't social security systems in countries that provide them with the compensation that they need to cover their loss of earnings and the medical expenses that they're going to occur. So please, medical surveillance clearly needs to be understood that it's a measure of how well your controls have worked in the workplace.
Yeah, and any form of health surveillance, medical surveillance works better for more acute illness, anyway. So if you're getting sort of respiratory irritation, that can be sort of, the cycle on that, or any sensitization, something like isocyanate, for example, you might pick that up earlier, and therefore be able to intervene, and health surveillance can be helpful with that. But yeah, as you say, by the time somebody gets picked up for an exposure to silica or asbestos and it's manifesting itself as a disease, it's already too late. And that's the tragedy of it. So yeah, definitely no, an over reliance on it. Saying that, it is important to record these incidents, and that's a key thing as well, to make sure that exposure is recorded in the right way. And I would suggest people are counselled, certainly where I've investigated exposures to asbestos. People can be very concerned about the effect it might have on them in the future, and they will need information and advice. So dealing with that very sensitively, is really important as well. You don't want to unnecessarily scare them, but at the same time, you've got to help them understand that it is serious, and they may need to look out for signs and symptoms as they move forward in their lives. Sorry, Kevin, you got your hand
Yeah, I
up.
was just going to just say something that Dr. Harrison said in one of his webinars or podcast. I can't remember. He basically said, if you have a sick worker, you have a sick workplace. So it's really important that there's a link back to the workplace, and the doctors need to kind of understand what the worker was doing, and there needs to be a feedback loop to the workplace to, to stop it happening to other people in the workplace. Just thought I'd throw that in.
Yeah.
You know what, I think that's a wonderful line to kind of start drawing our webinar to an end. I know that it's already 1:30. And before I do a close, I'd like to ask each of you, and Claudina, if you would like to offer a response as well, I'd be very grateful. For you, what do you think the key take-home message would be for OSH professionals where they have workers working with either asbestos or silica? Shall we start ladies first? Claudina? I've caught her unawares. Sorry, Kevin, you want to go ahead?
Yeah, just we have a Workplace Health Without Borders Healthcare Working Group that you're on, Karen. And Bert Burney's actually been using the WHDB webinars, especially on the ones on engineered stone, for example, to educate the doctors that he mentors. And, I think, just a take-home message here is if people can look at those webinars and share them, they're a great education resource just to raise awareness as well.
Great, thank you. Sean?
Yeah, I'd say the same thing. I mean, just to make the point that there is no safe level of exposure to asbestos or silica dust. Although we have these limits, we should be reducing them to as low a level as possible. Legacy remains a big issue in our building stock. Certainly in the UK, we've got a lot of asbestos still in buildings. So getting the right survey done using UCAS accredited surveying company. And just to pick up on Kevin's point as well, I think education really matters. If I love education, but when you go out there and you talk to people and what do you understand about the hazard and your risk of exposure, people don't always understand, and young people in particular aren't maybe being made aware of these hazards, and they're the ones now, they're probably hard to reach groups, so they're going into buildings and doing works, or they might be newly on a construction site and cutting bricks and so on, and inadvertently exposing themselves to these hazards but not realizing it. And our young generation are fortunate because they're probably going to live until they're 100, but some of them, it'll be absolutely tragic if they have their lives cut short. And some of these diseases manifest themselves in when people are in their 50s. And 50 is not old, 50 is a new 40, so I'm told. Now I'm in my mid 50s. So protecting people's long-term health, creating a sustainable workforce is really important, actually. And I think just to say, sorry, Karen, I'm going on a bit, but the health and safety community, the health and safety professionals have a real responsibility here to be advocates for good control, using the right people at the right time. So, getting an OC hygienist in at the right moment to give good advice, technical advice, are very highly skilled and qualified to do that, and also getting the right survey and information done. But very importantly, educating the workforce so they know, because they're the ones actually that need to know. Somebody did mention a question about making sure that if you do use respirators, which are probably the thing that people use, they must be fitted correctly as well. So a respirator is useless if it doesn't fit, or you're trying to put it over a massive beard or something like that. So an over-reliance on PPE sometimes is a problem, and we need to recognize it as OSH professionals that we have a responsibility to advise on those things.
Right. And Claudina?
Yes, apologies for that. I was typing. So by the time I got to the, I'd missed my opportunity. I wanted to just mention, I agree with 100% with everything that's been said. I think that legislative requirements need to go beyond compliance. So there's no such limit as a safe limit. Importantly, for both silica and asbestos exposure, we need to be mindful that the disease that's caused by that exposure is irreversible. So that's what's very important, is to prevent the exposure. And the irreversible disease also predisposes to other diseases of the lungs. So people who develop silicosis and asbestosis or mesothelioma can also develop or are at a higher risk of developing tuberculosis, for example, if we think about low and middle income countries, so particularly. So that's important to remember, is that it is irreversible. Thanks.
Yep. So I'm going to bring the session to a close. You will see that the 3 questions will come up on your screen again. Please, if you can just tick those and fill in the evaluation, we'd be very grateful. I want to thank all of my speakers, Kevin and Sean, planned speakers, and Claudina for jumping in at very short notice. We could go on possibly for another hour, but I think the webinar today has just shown how important this topic is, that we need to speak about it. I mean, I often fear that things like mental health and psychosocial issues are getting so much attention that things like asbestos and silicosis that really are life-limiting are in the shadows. And we as professionals, as Sean was saying, we need to bring these to the attention of our workers, and we need to take accountability for what is going on in our workplaces. So again, I'd like to encourage all the UK participants, if you please can go and sign that petition. We would be very grateful for your support. Also, don't forget membership to bodies like ICOH, IOSH, Workplace Health Without Borders, etc. is very beneficial to your professional development. So please, I encourage you to look at these organizations and join them. On that closing notes, Sean, you'd like to say something?
Yeah, I'd be remiss of me as Vice Chair of Construction Group, the IOSH, because if I didn't say we're hosting a lot of other webinars going forward. Actually, we've got planned around AI, more health stuff as well. So health in construction, temporary works, Building Safety Act, all of those things. So please keep a lookout for those webinars. They'd be really useful for CPD.
Thank you. Kevin, closing
Yeah,
note?
just one more plug. Please look at the Occupational Health Clinics for Ontario Workers website and look for the silica control tool and find out more about it. It's a fabulous tool. And I also just want to acknowledge the Executive Director, the Kimberly O'Connell, for bringing it across to Ontario. I think a lot of other countries are looking at it closely at the moment. So please just have a look at the tool and see if it can work for you. Thanks.
Thank you. So on a closing note, please, let's all be safe and healthy out there. And until we meet with another webinar, which there most definitely will be one, I wish you all a good day. Thank you all very much. Bye-bye.